allow me to introduce Dr. Ndagurwa, who's our first presenter for this session. So she's a specialist obstetrician and gynecologist, a fetal medicine fellow, a consultant at Salim Gabe Fetal Medicine Unit, clinician in charge of Fetal Medicine Unit Salim Gabe, and also works in the private sector. So she'll be taking us through importance of pregnancy dating and fetal growth assessment. Let's put our hands together for Dr. Ndagurwa.
Yes. Morning, everyone. I'm Dr. Ndagurwa, and I'm going to take you through a standardized approach to pregnancy dating and fetal growth assessment. Two of my colleagues are going to discuss in more detail on fetal growth assessment and Doppler studies. So in the interest of time, I'm going to dwell more on pregnancy dating. Okay. I'll go through the background, factors that we should consider before dating a pregnancy dating in the first trimester, second trimester, and in the third trimester. When and how to redate a pregnancy, and lastly, I'll go through fetal growth assessment. Okay, so for starters, an accurately dated pregnancy is a result of good history taking and evaluation. So this is going to be my take-home message. We have to go through the patient's history, we have to evaluate, and then we come up with correct pregnancy dates. So the correct pregnancy dates are very important in the management of pregnant mothers because they influence the timing of appropriate obstetric care. When we are going to review the patient, what we are going to do for the patient as in interventions, scheduling and interpretation of antepartum tests, assessment of appropriateness of fetal growth, coming up with interventions to prevent and manage preterm birth, postterm birth, and their related morbidities. So to sum it all, accurate pregnancy dating reduces perinatal morbidity and mortality, and it is of importance in research. Okay, so there are several tools that are available for pregnancy dating. The main tools that we use are the last normal menstrual period, first, second, and third trimester ultrasound scans. We also have online methods these days, and we also have art-derived tools that we can use. What is important in accurate pregnancy dating is to come up with what is referred to as the best obstetric estimate. The best obstetric estimate, we get it from information from the last normal menstrual period, the first accurate ultrasound scan, or both. What am I saying? We have to ask the woman about her last normal menstrual period, and then we validate those dates using the first accurate ultrasound scan. And if the dates are not correct, then we redate using the scan dates. If the dates are in keeping, then we keep on using the last normal menstrual period. Those dates are referred to as the best obstetric estimate. In first world countries, those dates are actually recorded on the birth certificate. Okay, on the birth record, sorry. So once we establish the accurate dates, we have to discuss these dates with the patient. And we have to document this clearly in the patient's notes so that the patient will not move from one review to the other, being redated on every review. So we need to document accurately in her notes so that everyone will stick to the dates that have been established by the first person who saw the patient. Okay, so we'll go through the first two that I mentioned, the last normal menstrual period, which is of historic importance, and maybe the only tool that is available in some local clinics. So when using this tool, there are factors that we should consider. The patient should not be on any method of contraception for at least 3 months prior to conception. The patient should have had 3 normal menstrual cycles before falling pregnant. It's based on the assumption that the woman is having a 28-day cycle with ovulation occurring on day 14. Hence, the period of gestation is calculated as 280 days from the first day of the last normal menstrual period. So we are referring to the first day, not any other day. To that first day, we use the Nagel's rule, where we add 7 to the date, we take back 3 from the month, and we add a year. We add 1 year to the year. Then we come up with the expected date of delivery. However, this method has some pitfalls. For the women that we deal with, only 50% are going to recall a date as their last normal menstrual period. If we have 100 women, only 50% are going to give us a date. However, in those 50%, almost 40% of women who give us a date as their last normal menstrual period, 40% of them will pick a wrong date. This was noted by Bennett K. in 2004 when they validated last normal menstrual period dates against the first trimester ultrasound scan. In 40% of the women, they noted that they had given wrong dates. Okay. So 1 in 2 women will give us a date. If we take 100 women who have given us a last normal menstrual period, 40% of those dates will be wrong. What am I saying? Using the last normal menstrual period tool for dating will make you wrongly date 75% of the women, about 75% of the women, which is a huge number. So what do we have to do? We have to move to ultrasound scan dating so that we can validate the last normal menstrual period dates. In the first trimester, a woman can present very early, like before 6 weeks. And when you scan her, you can only see a gestational sac. The gestational sac is not accurate for dating pregnancies. However, it has its role in determination of progress of a pregnancy versus the expected milestones Say if we're scanning a woman at 6 weeks or 7 weeks, we have a certain measurement of the gestational cycle. We have an expected milestone of noting an embryo or a fetal pole inside the gestational cycle. So I'm just giving an example of where the gestational cycle is applicable. So we can't say a woman is coming, she was dated at 5 weeks, then we rely on those dates. Researchers have noted that the gestational cycle alone is not accurate. Rather, we use it for confirming progression of the pregnancy against expected milestones and also confirming location of a pregnancy. The most accurate way of dating a pregnancy is the 11 to 13 weeks plus 6 days. Okay, so for the 11 plus 0 to 13 weeks plus 6 days scan, I think Dr. Verenga demonstrated that we need the fetus to be in mid-sagittal position. We should have the head in a neutral point with a pool of liquor between the chin and the chest. We should have the genital tubercle visible, which is this part. Dr. Verenga showed this part when he was scanning. And here, this is the pool of liquor that I'm talking about, and the strict mid-sagittal position that the fetus should be in. So the probe should be at 90 degrees to the lie of the fetus. The fetus is in strict longitudinal lie, and our probe is coming like this at 90 degrees to the fetus. So it was demonstrated during the live scanning that we take the maximum length from the crown to the rump. As we measure, there should not be any part of the baby beyond the caliper, and also on this side, no part of the baby should be visible beyond the caliper. So we take 3 discrete CRL measurements, and the machine will calculate the mean CRL and give us the expected date of delivery and gestational age. Okay, most of our women present in the 2nd trimester. So when they come in the 2nd trimester, we make use of the 2nd trimester ultrasound scan. And in this case, we'll be using the head circumference for dating. Of course, we obtain all the other parameters. Sorry about that. Okay, sorry, the cancer is too sensitive. So in the 2nd trimester, I was saying we use the head circumference, but we have to take the other parameters, the abdominal circumference, biparietal diameter, and the femur length. In the 2nd trimester, assessment of these parameters gives us an opportunity to assess the fetal anatomy. We cannot measure until we have confirmed normalcy of every region that we are assessing. So we've obtained all these measurements, but we refer to the measurements of the head circumference for pregnancy dating. The correct plane for obtaining this measurement is the transthalamic plane. So on the head, we can have different planes. We have the transthalamic, we have the transcerebellar, we have the transventricular. So for dating, strictly, we use the transthalamic plane. the other planes can be used for assessing other things. Okay, so these images are just showing the correct images for the fetal length assessment and the abdominal length, as the abdominal circumference measurement as well. So ultrasound scanning is user dependent. If you take this part and measure it as the femur length, the machine does not think. It will just record this short part as the femur length. So you as the user, you have to be qualified enough to assess all the structures that you are seeing and pick the correct structure to measure and place the calipers correctly on the structure that you want to measure. So for the femur length, as you can see, the calipers should be placed on the wide part of the bone there, excluding the epiphysis. So we measure all the way in a longitudinal plane to the other end of the bone, and we also exclude the epiphysis. So this femur length will then, the measurement that we get will be entered into the machine, and the machine will give probable days for that measurement. For the abdominal circumference, we also have strict parameters that we should stick to when checking for the when assessing the abdominal circumference. So we need to see the vertebra posteriorly, the stomach on the left side, and the portal sinus in front of the vertebra. We need one rib on either side of the abdominal circumference. We place the calipers around the abdomen to get the circumference at the level of the skin, not the ribs. So once we do that, we have adhered to strict standards of obtaining the biometry that we need. And then for now, we capture these readings, we go to the head circumference and assess the gestational age and expected date of delivery. The other parameters will be useful for assessment of fetal growth. Okay, in the third trimester, it is a very tricky period to assess gestational age because the margin of error may get even up to 30 days, 21 to 30 days. So when we get a patient in the third trimester, we should not be quick to redate that pregnancy. In that period, growth is affected by different things. There are a lot of confounding factors for us to end up having an estimated fetal weight. So you have a pregnancy that needs dating in the first trimester. You have to go through the full clinical picture, go through the risks of the patient and assess everything else before you rush to assign dates. For assigning dates in this period, we use the head circumference. Once we assign dates, we have to check for interval growth. After 2 weeks, we ask the woman to come back so that we can assess for interval growth. If the patient has been dated earlier on, it's not advisable to redate a pregnancy in the third trimester. This is only reserved for unique cases where maybe the first scan was done by someone who is not experienced. In fact, all you need to redate a pregnancy in the third trimester, you have to consider redating, reviewing the woman after 2 weeks to assess for interval growth. Okay, so that's pregnancy dating. So I'll move on to pregnancy dating in the singletons. I'll move on to pregnancy dating in multiple pregnancies. In multiple pregnancies, of course, we ask the woman about her last normal menstrual period, and then we go on to perform the first trimester scan. On the first trimester scan, we check the CRL measurements of all the fetuses present. Then we use the measurement of the bigger twin or triplet. If the woman is presenting in the beyond the first trimester, we use the head circumference of the bigger twin or triplet. Okay, so when we have to redate pregnancies, I've already mentioned that we consider the last normal menstrual period the first accurate scan that we have. If the first accurate scan that we have is the first trimester, and there's a discrepancy of more than 7 days between the last normal menstrual period days and the scan days, we redate. If it's in the second trimester, we have a discrepancy of more than 14 days, we redate. In the second trimester, in the third trimester, a discrepancy of more than 21 days, we also redate. As I mentioned earlier on, when redating, always ask the woman to come back after 2 weeks to assess for fetal interval growth. Okay. So I've been explaining a standardized approach to dating where we consider the last normal menstrual period, we perform the first scan, assign dates, and then if the dates are in keeping with the last normal menstrual period, we don't redate. If they are not in keeping, we consider the discrepancy and then we redate. Okay, lastly, I'll talk about fetal growth assessment. I have 2 of my colleagues who are going to delve deeper into fetal growth assessment and Doppler studies. I will just mention it in passing. Fetal growth assessment is important, and it's usually done from 14 to 40 weeks, depending on the risk of the woman. For fetal growth assessment, we obtain biometric measurements, the head circumference, abdominal circumference, femur length, and biparietal diameter. In our units, we are using the Hadlock formula, where we use the head circumference, abdominal circumference, and femur length. There are several formulae that can be used depending on the unit that you work in, but the Hadlock formula 3 was noted to be the most accurate formula for assessing the estimated fetal weight. It is important to assess the estimated fetal weight because it reduces the perinatal morbidity and mortality. Small or large babies are at a more increased risk of dying in utero or in the early neonatal period or up to 1 month post-delivery. They also have complications in adult life. So it's important for us to assess fetal growth. Once we take these measurements, the machine will then plot on the estimated fetal weight graphs where we have the 3rd to the 95th center. And then we have to check where the baby is falling in terms of the centers. If they are falling below the 10th center, then it means they are not doing well, they are small. If they are falling above the 95th center, then they are too big. Then the ones who are not growing well will need further evaluation using Doppler studies. In all these fetuses, we assess amniotic fluid as it is also affected when the baby is not growing well. These are my references. Thank you.